Welcome to the 100. All right. Welcome to the 118th. Is somebody, I'm hearing a lot of background noise. Okay, welcome to the 118th quarterly meeting of the Advisory Commission on Childhood Vaccines. This meeting is being recorded. If you object, you may disconnect at this time. I will now turn the meeting over to the ACC Vice Chair, Ms. Karen Kane.
Hi, good morning, everybody. This is my second Vice Chair meeting that I'm hosting. So I just want to welcome everybody, and I guess let's get started. Samara, can you help me?
Sure. So we have 3 new members who are joining us today. So and they are Daniel Boyle, who is representing the general member of the public. We also have Dr. Albert Holloway, who is a pediatrician, and Dr. Dana Deshawn, who is a nurse practitioner. And so they are the new members. And so we'll give them an opportunity to tell us a little more about themselves. And so how about Daniel, if you go first?
Okay, thank you. Yeah, I'm Dan Boyle. I learned about the commission in 2009 after I experienced a vaccine injury. It wasn't until a couple of years after that that I actually got all the information that I was eligible under the program for a claim. And it was through Ed Kraus, who was serving on the commission at the time, an attorney, who helped me a great deal, really validated what I was going through, and kind of planted a seed about applying to be a member of through the general public position, and that was a number of years ago. And I'm grateful to be here. I thank everyone who was part of the process of my application and the orientation materials. I appreciated those, the video, and I'm looking forward to being a part of this process and team, and I hope I can make a contribution.
Okay, thank you. So how about Dana, if you go next?
Yeah, thank you. So my name is Dana Deshawn. I'm a pediatric nurse practitioner. I have a doctorate in nursing as well. I have been in, my main role has been as a primary care pediatric office nurse practitioner. I've been in that office for 23 years now. And I'm also part of a National Association of Pediatric Nurse Practitioners. That's actually how I think I heard initially about the ACCV opportunities. And so I'm on the immunization chair for that. I have a love for vaccines. I have done numerous vaccination talks through the local national conferences, radio, TV, and then with the community at large. I reside in Illinois, I'm married, and I have 5 boys of my own between the ages of 21 to 12. And so we're pretty busy right now with activities. I'm very honored to be part of this board. So thank you.
Thank you and welcome. And how about Dr. Holloway?
Sure. I'm Albert Z Holloway. I'm a general pediatrician in Montgomery, Alabama. I guess I've been practicing now for about 42 years. And worked in several different settings, community health centers, mental health centers, and as well as private practice. Currently working in the mental health center, doing medication management and also doing general pediatrics within a community mental health center. Been active with my state chapter out of Academy of Pediatrics, served as as a former president of that chapter and worked some nationally with the National AAP. I've always been an advocate for immunizations, and I'm excited to be part of this group. And thank you for all those people who took care of the processes necessary to get me here.
Thank you. Okay. So welcome all the new members, and then we'll let Karen and Bill Spiegel introduce themselves to the new members too, just so you know, those are the other two members. So Karen, you want to go next?
Of course. Thank you. And welcome, everybody. I'm very, very excited to have you part of the board. And I know it's a lot to take when you first come on, because even though there's a lot of reading and research, it's just an experience I think like no other. I'm very happy to answer any questions you have. I am a board member because of my daughter, Lauren. She was injured by her DPT vaccine in 1994. She had the live vaccine, and the HHS immediately agreed that my daughter was vaccine injured. She had a table injury. She had severe brain damage and encephalopathy. She was cortically blind, nonverbal, quadriplegic, fed through a feeding tube. She had a trach and a tracheal diversion, and she died at home when she was 15 years old. So I'm a health freedom advocate, and I've been speaking about vaccines and vaccine injury and health safety for about 27 years. So I'm super excited to have the board, you know, becoming more full. I know we have a little bit of ways to go, and hopefully we can get another parent on the board and all the positions filled so we can have appropriate and equal conversations. Thanks.
Bill, you want to introduce yourself?
Yeah, sure. Good morning, everybody. My name is Bill Spiegel. I'm a partner with the law firm of Brawl and Henderson in New York City. All of my practice is really devoted to the defense of physicians, nurses, nursing homes, anything medical, dental, healthcare related in any way. All we do is defend. I am not one of the attorneys who litigates directly in this field involving the vaccines that are on the table of compensated injury. So we've had attorneys, and hopefully we will, who do this stuff every day. I have an interest because when I started my career about 25 years ago, for many years I defended the New York City Health and Hospitals Corporation and their various hospitals, and I saw a lot of vaccine-related lawsuits. So I've kind of become somewhat invested in this and have an interest, and that is why I'm here. And I'm happy to have new people on board.
Thank you, Bill. So the other thing, I just want to give you all updates. We are working to get additional members, and hopefully we will have 2 additional members for the December meeting. We hope so. We have our fingers crossed. So yes. So Karen, you want to get started with the meeting and minutes? And
Okay, I'll be there.
Yes. Okay. So, I'm looking at the agenda. So have we done the welcome chair report? We've done that. Are we doing?
Oh, so you can do
comments?
Yeah, you can do the public comments at this point. Yes.
Okay. I welcome any public comments.
Okay, if participants are dialed in and you'd like to make a public comment, please press star 9 on your phone, and that will alert the meeting host that you want to make a comment, and you can be unmuted. If you're using the web platform, the Zoom web platform, and you'd like to make a public comment, please use the reactions button on the bottom right side of your screen to raise your hand, and we can unmute you so you can make a
Okay. I guess there's no public comments.
Yeah, we're not seeing any raised hands and haven't been alerted to anybody on the phone wanting to make a comment.
Okay. So I think that's the first time for me. let's move on to approval of the March 4th, 2021 meeting minutes.
So does anyone move to have the minutes approved? And then someone can second it? If there aren't any, if no one has any suggested changes.
I'll move
Yeah, I move to. After you,
Go ahead,
Karen.
Bill. I'll move to approve the minutes.
And I second that.
And then all those in favor, say aye.
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 So,
Okay.
mhm.
Sorry, am I doing this? So I would like to move on to the report from the
So-
Division of Injury Compensation.
So,
Sorry?
yep, so the minutes are approved. So I wasn't sure if we heard from either Daniel or Dr. Holloway to approve the minutes.
This is Daniel.
Okay,
I read the minutes. I wasn't in a position though to determine
Okay.
if, they're accurate or.
okay, okay, okay.
Okay, I reviewed them, but again, this is my first meeting.
Yep,
So,
okay, all right.
okay.
So for those that did approve, okay, so the minutes are approved. So just so we have that for the record. Okay. And then, so I've been talking a lot and I haven't introduced myself. My name is Tamara Overby and I am the acting director of the Division of Injury Compensation Programs. And it's our responsibility in this division to coordinate and administer this commission. And Annie Herzog, who most of you all have interacted with, is the principal staff liaison for the ACCV. So if there are any concerns around the ACC, for the most part, reaching out to Annie. I am considered the designated federal official for this advisory commission. And so it's my job to oversee the commission. And then today I will be presenting on and providing updates on the National Vaccine Injury Compensation Program. So Annie or Amber, you want to put those slides up?
Okay, are you seeing them,
Yes,
Tamara?
yes, I
Okay.
am. Mhm,
Perfect. Okay.
All right, thank you. So this morning I will be giving you all an overall update about the Health Resources and Services Administration's Vaccine Injury Compensation Program. Annie, they advance. Okay, can you? Annie, the slides need to be advanced one more. Okay. Yep. And also today, the Department of Justice will be providing their update on their vaccine litigation activities, as well as we'll have updates from the ACCV ex officio members representing the Food and Drug Administration, representing the Centers for Disease Control and Prevention, representing NIH and the Office of Infectious Diseases and HIV/AIDS Prevention provide us updates today. Next slide, Annie. So this is a slide reflects the number of claims that have been filed in the program as of September 1st, 2021. And so far this fiscal year, we have had 1,834 claims filed by adults. We've had 117 claims filed by children for a total of 1,951 claims filed so far this year. So we're likely to approach about 2,000 claims by the end of the year that would have been filed for the program. Next slide, Annie. Again, this slide reflects the number of claims we've had filed. It just shows it graphically. And this slide reflects the fact that we have had a dramatic increase in claims filed over the last 5-6 years, and that the majority of the claims that have been filed, the red line, have been filed by adults, and that the number of claims filed on behalf of children has pretty much stayed steady. Next slide, Annie. Also, this slide reflects the fact that we've had an increase in claims filed, but not necessarily the commensurate increase in claims funding. And so that's what this slide reflects. And next slide, Annie. And as a result of us not having sufficient funding, we do have a backlog of claims. At this point, there are about 1,500 claims that are in our backlog. And some of these claims have not been activated by the PAR, but these are the claims that have been filed that ultimately either they're in the PAR or we don't have sufficient staff at this point to review them, so they're part of the backlog. Next slide. Go back one more. So as far as the awards that have been paid this year, so far, as of September 1st, 2021, for this fiscal year, we paid a little over 200 million in petitioners awards, and we paid out about 33 million, a little over 33 million for attorneys fees and costs awards. Next slide, Annie. Okay, so the number of claims that have actually been resolved or adjudicated this year as of September 1st, we have determined that for fiscal year 2021, that 635 are compensable, 221 have been dismissed, and for a total of 856 adjudications. And I just would like to remind everyone that the court is the one who actually determines whether claims are compensable or dismissed. We're just reporting on the data. So next slide. As far as the types of claims, the types of compensation categories, so far in 2021, as we stated, there have been about 636 compensable claims, and 280 of those have been concessions. And a concession is where the Department of Health and Human Services concedes or agrees that the vaccine actually caused the injury. And then there were 16 court decisions, which in essence, the court is deciding or has made the decision that the vaccine caused the injury. And then we have 340 that have been decided by settlement. And with a settlement, it's basically, settlements can happen for various reasons. And in the case of a settlement, the federal government is not saying that the vaccine caused the injury, because like I said, settlements can be for various reasons. And there were 222 that were not compensable for a total of 858 adjudications so far this fiscal year. Next slide. So this is just to give an update on the Vaccine Injury Compensation Trust Fund. The trust fund is what funds the payment of claims, as well as funds the administrative expenses for the Department of Health and Human Services, the Department of Justice, and also for the court. So currently, the balance in the trust fund as of June 30th, 2021 is over $4 billion. And you can see where the sources of the revenue are. So there's excise tax money that comes in. There's interest from investments for a total income of almost 183 million. Next slide. So here are some trends that have occurred with the program over the last few years. As I mentioned earlier, that 90% of petitions are filed for adults in the last 2 fiscal years. And over 54 petitions filed in the last 2 fiscal years are alleging the injury of shoulder injury related to vaccine administration or SERVA. 73% of petitions filed in the last 2 fiscal years alleging injury from the influenza vaccine. About 60% of the petitions filed are compensated via negotiated settlement. And then, as I mentioned about the backlog, we have nearly a 13-month wait for petitions to be reviewed by a HRSA physician after the pre-assignment review activation date. So that's basically the date that the court has determined that there are sufficient medical records for the claim to be reviewed. Next slide. As I mentioned too, we are always seeking nominations for ACCV members. Even if we have slots filled, we're still accepting nominations for members just to have a pool of members to be able to select from. So if you're aware of people who are interested, or you know people who may be interested in serving on the ACCV, please send their resume or their CV to Annie, and her contact information is below. And just since we have some new members here, I just want to kind of go over the categories of individuals that or the categories of expertise that we look for, individuals that we look for. So the ACCV, and this is stipulated in the Vaccine Act that created the advisory committee. It stipulates specifically that these categories of individuals are to serve on the advisory committee. So we have to have 3 members who are health professionals who have expertise in the healthcare of children, the epidemiology or etiology and prevention of childhood diseases, and 2 of those must be a pediatrician. The other category, we have to have 3 members of the general public, of whom at least 2 shall be a legal representative of a child who suffered a vaccine-related injury or death. And then the final category is that we have attorneys. We have to have 3 attorneys. 1 shall be an attorney who specially includes representing persons who suffered a vaccine-related injury or death. And the other, another attorney has to be an attorney who specially includes representing vaccine manufacturers. And then we have a general attorney. So those are the 3 types of attorneys that we have on the commission. So if you know of any individuals that are in those categories, please, like I said, send their CV or resume to Annie. And moving on to the next slide. And that's just Annie's contact information if there's a need to communicate with her. So I'm willing to take any questions at this point.
This is Karen. I have a question.
Mhm.
Do you think, I saw at the very beginning of the report that the claims were up this year. Do you think that was because of the MPRM coming off the table, that there was a rush to get everybody's injuries?
Yes, because in the month of January alone, we had nearly 800 claims filed just in that month. And yeah, we were assuming that it's because of the expectation that that NPRM would become effective, the one that was proposing to remove SERVA. And so there was a push to file those claims before that NPRM became effective. So yes, because we've never had 800 claims filed in a month, and that was like really unusual for that to occur.
And then my second question is, when you were talking about the backlog,
Mhm.
I know on many conversations it has been said that the children are put before the other injuries, or is that for that backlog, is it just all the injuries, or are we prioritizing the injuries from the children?
So what we have separate teams that review the pediatric versus the adult claims. And so there's not a backlog with the pediatric claims. The number that you see there, Annie, I don't know if we could go back to it. The number that's there, the 102, those are the ones where those are claims that have been filed that the court hasn't determined that there are sufficient medical records for them to be assigned for review. So this 102 here are ones that the court hasn't determined that they have sufficient medical records to be reviewed. So they're not ready for review.
Thank you so much. Okay.
Are there any other questions? So Annie, I'm not sure, you may want to look and see. I'm not sure if people's hands are raised or whatever.
I don't see any
Okay.
at this time.
All right.
Thank you, Tamara. So we can move on to the report from the Department of Justice by Heather Perlman, Deputy Director, Torres Branch, DOJ.
So you'll need to unmute Heather, Annie.
Can everybody hear me?
Yes, we can.
Yes.
Thank you. Good morning, everyone. I am Heather Perlman. I am the Deputy Director in the Torts Branch at the Department of Justice. Our office represents the Secretary of HHS in cases filed under the Vaccine Act. The report, and Annie, will you put up thank you, our slideshow, thank you. Just a reminder that the statistics on which I'm going to report, it is a different reporting period than what Tamara just gave for the HHS, which is why the numbers will be slightly different. During the reporting period, which was from May 16th through August 15th. There were 342 petitions filed, 24 were filed on behalf of minors, and 318 on behalf of adults. Next slide. The total petitions adjudicated during this reporting period was 221. Of those, 175 were compensated, and 46 were not compensated or dismissed. You can see the breakout of the compensated cases and how that went down, whether it was conceded or not conceded by HHS.
So
Next slide.
I'm sorry. So Heather, this is Tamara. So Annie, is there something going on with Heather's slides? They don't look like they're completely showing all of the text that she's talking about. I don't know. Let's see.
I actually noticed the same thing, but I
Yeah.
thought maybe it was just me.
No, it's something. Yeah, I don't know if you want to reload the slides or something, Annie, but they're not
Yeah,
showing.
let me try.
Okay.
Okay, let me.
Okay.
Sorry, if you could just give me 1 second. Yeah, it's looking that way. So I don't know if there's something going on with my.
So Heather, you want to see if you can upload them? I don't know if Annie can give you control. How
Or
about,
if someone could send them to me, email them to me real quickly. And we only have the PDF. If someone could send like the PowerPoint, maybe that would work.
Ida, I believe you are on. Would you mind doing that, please?
Oh, there we go.
There we go.
Thank you, Amber.
Okay. Yeah, slide 3, I believe, is where we left off. Total petitions adjudicated during the reporting period was 221, 175 were compensated, 46 were not compensated or dismissed. Next slide. There were also 34 petitions that were voluntarily withdrawn this reporting period, and no judgment will be issued. I think you're a couple slides ahead. Yeah, there we go. Ooh, one more. There you go. The next section is about the appeals. The first slide is the cases that have been decided during this reporting period at the federal circuit. 2 appeals by petitioner, both were reversed and sent back to the special master. That's Kirby and Cotton Steady. Next slide. There is 1 appeal by petitioner that is currently pending. That is Sanchez versus HHS. Next slide. And there's 1 appeal filed by respondent, and that is Wright versus HHS. During the reporting period, there were 7 cases that were decided at the Court of Federal Claims. 4 were affirmed, 3 were remanded, and you can see what the issue was, whether it was entitlement or attorney's fees on that slide. There were also 2 cases in which respondent appealed during the reporting period that were decided. One was affirmed, that was Gross, and one was remanded, that was Lemming. Cases pending at the CFC, 9 appeals by petitioner, 6 deal with entitlement, 1 deals with damages, and 2 deal with attorney's fees and costs. There's also 1 pending case that respondent appealed, that is Flores. It's an entitlement issue. Skipped a slide on oral arguments. There we go. There is a correction. There is an argument scheduled now at the Federal Circuit in Wright versus HHS, and that argument has been scheduled for October 7th. There is also an argument scheduled at the CFC in Bull. That's on September 15th. The next section is the adjudicated settlements during this reporting period. There were a total of 102. Slightly more than half were settled 2 years or less after the petition was filed. Approximately 70% involved the flu vaccine, and about 62% involved shoulder injury related to vaccine and shoulder injury related to vaccine administration, SERVA. I will note that there is an error on line 85. It should be reversed, the TM and the flu. It's obviously the flu vaccine, and the alleged injury is transverse myelitis. And that is our presentation. As always, at the end, we have our appendix that contains the glossary of terms, how a petition is processed in the Office of Special Masters, the levels of appeal in vaccine cases, and the appeals process. That is my presentation. Thank you.
Thank you, Ms. Perlman. Does anybody have any questions
This is Dan Boyle.
or comments?
Just a clarification. That last piece on the adjudicated settlements. So those are ones decided by the court and those that are settled.
So everything is just, I'm sorry, I didn't mean to speak over you, Mr. Boyle.
So that's the total of claims settled, so to speak, by the
Yeah,
court
so
or by the.
every case is decided by the court, whether it's a settlement or not. It's just how it is presented to the court. Settlement, which is the vast majority of how cases go through the program, is the 2 parties, the Department of Justice representing HHS and the petitioner, agree to negotiate a settlement. And normally there is not a concession about liability, but both parties believe it is in the best interest to go this route. We present a settlement stipulation to the court, and the court almost always adopts the parties' agreement. I suppose they could choose not to, but that I don't know if that ever happens. Did that answer your question, Mr. Boyle?
Yes, it did. Thank you.
Are there any other questions? Okay, I think we should move on. Thank you again, Ms. Perlman. I'd like to welcome Mr. Duffy. He's going to update us on the Immunization Safety Office Center for Disease Control and Prevention vaccine activities.
And he also, Jonathan needs to be unmuted.
This is Jonathan Duffy. I'll be presenting the update for CDC. So next slide, please. So there's been a lot of activities around COVID-19 vaccines. So this first section will address that. So as a reminder, CDC's Advisory Committee on Immunization Practices currently has recommendations for these 3 different COVID-19 vaccines in the United States. those manufactured by Pfizer, Moderna, and Janssen. And the full recommendations are available on the CDC website. Next slide. So this slide just shows an update on the vaccinations administered in the United States. So this data actually comes from the CDC website and it's updated daily. This just represents the data that was available at the time these slides were prepared. So just to give an idea, there's been 364 million doses administered in the United States, which represents more than 202 million people vaccinated with COVID-19 vaccines. And this represents approximately 71% of the population greater than 12 years of age who have received at least one dose of vaccine. Next slide, please. So the Advisory Committee on Immunization Practices has continued to hold additional emergency meetings to discuss topics related to COVID vaccines. So since the last scheduled ACCV meeting, there have been 4 additional ACIP meetings, which I'll discuss in the upcoming slides. Next slide, please. So my slides here just really focus on the highlights of the safety issues discussed and presented at those meetings. So there's been an update, there's been multiple updates on the issue of myocarditis / pericarditis following the mRNA COVID-19 vaccines. So that is the Pfizer and Moderna vaccines. So there has been an elevated risk for myocarditis observed among mRNA COVID-19 vaccinees, particularly in males aged 12 to 29 years. On June 23rd, the ACIP concluded that the benefits of COVID-19 vaccination to individual persons and at the population level clearly outweigh the risks of myocarditis after vaccination. And ACIP continued to recommend COVID-19 vaccines be used in age groups because this will prevent morbidity and mortality from COVID that far exceeds the number of cases of myocarditis expected following vaccination. Some more information about this can be found and was published in the MMWR. Next slide, please. Another safety issue that was addressed at the ACIP meetings is the issue of Guillain-Barré syndrome after the Johnson & Johnson COVID-19 vaccine. So a summary here is that CDC and FDA are monitoring reports of GBS in people who have received this vaccine. For those who aren't aware, GBS is a rare disorder where the body's immune system damages nerve cells, causing muscle weakness and sometimes paralysis. Most people fully recover, but some have permanent nerve damage. So the data that was presented was that after more than 14 million doses of Janssen vaccine administered, there have been around 167 preliminary reports of GBS identified in the Vaccine Adverse Event Reporting System as of August 18th. These cases have largely been reported about 2 weeks after vaccination, and mostly in men and most cases in people 50 years and older. And so CDC will continue to monitor for and evaluate reports of GBS occurring after COVID-19 vaccination, and will continue to share more information in the future. And there's more information about this available on the CDC website. Next slide, please. So this is not a safety issue per se, but ACIP addressed the need for additional doses of mRNA COVID-19 vaccines as part of a primary series in immunocompromised people. So this refers to people who are moderately to severely immunocompromised, who are especially vulnerable to COVID-19 and at risk of serious prolonged illness. And the people with immune compromise may not build the same level of immunity to a 2-dose vaccine series compared to people who are not immunocompromised. Therefore, CDC recommended that people with moderately to severe compromised immune systems receive an additional dose of either the Pfizer or Moderna vaccine at least 28 days after their second dose. Next slide, please. ACIP has also continues to discuss considerations for booster doses of COVID-19 vaccines. And so this statement just comes from the CDC website. And again, for those who aren't aware, the goal is for people to start receiving a COVID-19 booster shot beginning in the fall, with individuals being eligible starting 8 months after they receive their second dose of an mRNA vaccine. And this plan is subject to authorization by the US FDA and recommendations by CDC's Advisory Committee on Immunization Practices. And ACIP will decide whether to issue a booster dose recommendation based on a thorough review of the evidence. So this is a topic that is going to continue to be discussed at future emergency ACIP meetings. Next slide, please. Since the last meeting, there have been 3 new vaccine safety publications related to COVID-19 vaccine safety. The first one was published in the MMWR in July and addressed, was an update addressing the use of COVID-19 vaccines after reports of adverse events among adults. The second one was also published in the MMWR in July and was an update on information on vaccine safety in adolescents. And then there was also a publication in the journal JAMA Cardiology addressing myocarditis after immunization with the mRNA vaccines. And links to these publications are available on the CDC website. Next slide, please. So now I'm transitioning to talk about other non-COVID related topics that were addressed at the ACIP meeting in May. So this first one was a vote that ACIP took related to dengue vaccine recommendations. This is a new recommendation that was voted on to recommend 3 doses of Dengvaxia, the dengue vaccine, administered as a series at 0, 6, and 12 months to persons aged 9 to 16 years of age with a laboratory confirmation of a previous dengue infection and also living in endemic areas. And so for the United States, endemic areas include the territories of Puerto Rico, American Samoa, and the US Virgin Islands. Next slide, please. So there was also a session on influenza vaccine. And so ACIP voted to affirm the updated statement on the prevention and control of seasonal influenza with vaccines for the 2021-2022 influenza season. This is a document that is updated annually, and it was published online in the WR just on August 27th after these slides were prepared, but the full document is now available online. And so this just, a second bullet just is a reminder that the core recommendation for influenza vaccines remains unchanged, and that is that annual influenza vaccination is recommended for all persons aged 6 months and older who do not have contraindications. And so the updates or changes for this year are listed here, and again, do not impact the overall recommendation, but just updates what influenza vaccines will be available, and the viral composition is reported there. As 2 of the strains have changed. For one vaccine, the flu Cellvax, the approved age range has been lowered from 4 years to 2 years of age. And then there was also updates on language related to timing of vaccination, co-administration of influenza and COVID-19 vaccines, and more information about contraindications and precautions concerning persons with a previous severe allergic reaction. So again, all that information is available in that published report. Next slide, please. ACIP also voted on updating a recommendation for rabies vaccine. At past meetings earlier this year, they had addressed similar votes for adults. This was a vote on persons less than 18 years of age, and this is just updating the recommendations based on more recent evidence regarding the number of doses required for pre-exposure prophylaxis. So the new recommendation is a 2-dose rabies vaccine series for persons less than 18 years of age for whom rabies pre-exposure prophylaxis is indicated. And that second bullet just provides more information on when additional doses should be given. Next slide, please. So ACIP also had a session on zoster vaccine, and this was just providing information reviewing risk of herpes zoster, severe disease and complications, and this discussion is around people in immunocompromised populations. And the policy question under consideration is, should vaccination with recombinant zoster vaccine be recommended for immunocompromised adults 19 years of age and older? And so this was an information-only session, and more discussion will take place at future ACIP meetings. Next slide, please. And ACIP also had a session on pneumococcal vaccines. So again, this was an information-only session. And there was information presented on 2 new vaccines that have been approved for use in adults. Those are PCV 15-valent and PCV 20-valent. And so just to summarize the policy questions under consideration are essentially, should these vaccines be routinely recommended in adults, and whether that should be for people over 50, over 65, and whether it should also be recommended in younger adults with underlying medical conditions. And how should these recommendations be made in relation to the previously existing PPSV23 vaccine. So again, more discussion will take place on these topics at future ACIP meetings. Next slide, please. That concludes my presentation, and welcome any questions. Thank you.
This is Karen. I have a couple questions, I guess, or comments. I know we didn't do June, so I think in March we talked about the different types of sites that people were supposed to report an injury, and I just have to say that my dad died last week of COVID, and my mom's actively dying. And when I went to the hospital with both of my parents numerous times, they sent my dad home immediately without any care, anything to treat COVID. And I was just looking at the testimony of Pierre Corey. That was a December 8th, 2020 testimony where he stated those hated words, ivermectin and the HCQ, and I know the Roganon is an IV treatment, but there is a protocol of vitamins and things to take, but I actually have to say, going through this experience, I was shocked. I sent this testimony to the hospital. I sent it to both of my parents' doctors. One of the doctors is now using it, but he also told me it was impossible for him to get those treatments. So as someone who's losing both parents in 1 week from COVID, I don't understand how our medical community is not supporting any type of other treatments and except just denying treatment. I mean, I've talked to 4 different people at the hospital 4 different times and 2 different doctors, and there is absolutely zero treatment for COVID. I begged for a Z-Pack. They, once they get him in with my dad, he was in the hospital for a week. Obviously, they're just going to give him Ativan and Holdaball. I don't know how to pronounce that, and morphine. But that's not a treatment, and I just have to say here, because I'm on this board, that I find it shocking, one, that there's no treatment at all, and even to say, I told the ER doctor, I said, my dad's going to die in a week because you refused to give any of these treatments, and the ivermectin, won the Nobel Peace Prize in 2015. But in saying that, so how many places are we reporting these injuries? Because it was a day or two later, I got a call at home on both of my parents about COVID, but they never talked about how to help them at home, how to support them with any kind of treatments like the quercetin and the zinc, which many doctors are taking and prescribing. So it seems like this is a very, very confusing time. I mean, I hear on the radio, it's almost like people are celebrating the deaths to prove that there's this virus that is killing people, but nobody that I can see, except alternative healthcare providers, are supporting any type of treatment for people who are dying. I really feel like this is crimes against humanity. We are not treating people, and they're actively dying. So that's my question. 2 questions, actually. Where are we reporting it, the death? And then why wouldn't the CDC or anybody just step in and try to help people to treat COVID?
Thank you for your comment and question. So as a representative of the Immunization Safety Office, I can't fully speak to the issues of treatment. I mean, I can just say that I know that there are FDA authorized treatments for COVID infection, and I believe that the NIH has clinical guidelines on the treatment of COVID infection, so I would have to defer those questions to other people. And when you talk about injury reporting, I would just say that related to vaccine safety per se, and people who are concerned about vaccine injury, CDC has 2 main systems that people can participate in. One is the V-Safe system for adverse events following vaccination. That's the one where people are invited to enroll in complete surveys about their post-vaccination experience. And then, of course, there's the vaccine adverse event reporting system for, again, people who have vaccine-related adverse events. When it comes to COVID infection, CDC is using different surveillance systems to collect information on deaths related to COVID infection. So there is information on the CDC website. And again, I'm not the appropriate person to speak to the details of that. But CDC is continually updating information daily on number of COVID-related deaths that are reported in the United States.
Thank you.
This is Dan Boyle. First of all, Karen, my condolences to you. And I'm sorry about the situation with your parents and your mom. And,
Thank you.
but it also raises raises a question. It goes back to the slides and reporting the data on VAERS and GBS, and it raises the question for me. I was very happy to learn about V-Safe this year because in 2009 there wasn't anything other than VAERS to monitor surveillance. So I'm wondering, is there data coming out of V-Safe about GBS or other trends? And is there any way that V-Safe and VAERS, quote, talk to one another? Do they know who is reporting and what overlap there is in those that data?
Yes, thank you for your question. The V-Safe system is, it's a voluntary system that people can enroll in. And so they are sent surveys. And so if they complete the survey and indicate that they had a serious adverse event, then that prompts follow-up and to either ask them to report it to VAERS. And in some situations, people are actively being contacted to collect more information about certain types of adverse events. So yeah, the two systems are meant to work together. And again, VAERS is meant to actually encourage and remind people to report their experiences to VAERS. So it's really meant to be complementary. And again, VAERS would be the actual database or system that would collect more information about, or more detailed information about those serious adverse events.
So V-Safe itself wouldn't then be a data set to look at them. They would hope that people would report it to VAERS, or are there things that they look at to find people with adverse reactions in V-Safe?
Well, in the example you mentioned about Guillain-Barré syndrome, for example, that would be a serious adverse event. So V-Safe doesn't have a question about GBS itself, but it asks if you had any serious events or had to go to the hospital. So V-Safe itself is a data set and does have the answers to those survey questions that ask about people's experiences, and that data has been presented at ACIP meetings, and there's been a few preliminary publications, and there's plans to share more information from that in the future. But again, a specific adverse event doesn't ask specific questions. So, when there's a general question about did you have to go to the hospital for an adverse event, that information would then be sent to VAERS. For specific conditions such as GBS, that information would be in VAERS, but V-Safe does, the general survey information is still being collected and will be reported on.
Thank you.
And hi, Karen, this is Claire from NIH. I'm so sorry for your loss and so sorry to hear about your mother. I did want to let you know that NIH is conducting studies, clinical trials, looking at repurposed drugs as treatments for COVID-19. So that's looking at drugs that are approved for other purposes and seeing whether they are effective against COVID-19. So after the call, I can send that information around to ACCV members, and also a link to the NIH treatment guidelines page.
Thank you so much. And I can send the report from Dr. Corey. I mean, I just have to say, I'm going to say two things. One, that I think is very important that we all understand that the Harvard Pilgrim study talked about that less than 1% of vaccine injuries are reported. And that's something which is on a purview for the ACCV board. I mean, that's highly concerning because I absolutely believe that these injuries are there are far more many injuries than being reported, and that was just in the Harvard Pilgrim study, and anybody can look up that study. And also, I found it shocking that in the community in Astoria, Oregon, that I could not get one person to help treat my dad or my mother, and it was very, very clear that both my parents, the virus attacked both of them, and it attacked their central nervous system. I actually thought my dad had a stroke, but I truly believe this is such a serious time, and there are crimes against humanity when we are not treating people with things like ivermectin, which is a totally safe drug, and being open. And every single doctor I talked to said the CDC does not approve that drug. And so I'm one of those people that have taken and given the horse dewormer, the ivermectin, however I can get it. There, if you look at the FLCCC, there's 25 degrees between those doctors that run that side, and they are helping people. But it also saddens me, and it shocks me that we canceled the June meeting. There's never been a time in history where we have such catastrophe amongst a virus that's killing people, and everyone refuses to treat. And I know part of it is because doctors are getting banned. I mean, nobody wants to be wake-fielded and talk about something that actually could possibly help. Sending my dad away from the ER, I had to talk to the doctor for 20 minutes to just encourage her to at least give my dad a Z-Pack. And I don't think a Z-Pack is helpful, but with the Z-Pack, it's crimes against humanity when we are doing nothing and watching people die and then happily reporting deaths so we can support a vaccine program. It's an outrage, and I think that's all I'm going to say, and I look forward to your email. Thank you.
So Karen, this is Tamara. So I also sorry to hear about both of your parents. But another source of information would be the Food and Drug Administration, because of course they're the ones who license drugs, and so that's another source of information. So I'm not, so Valerie, I'm not sure if Valerie's on the line where she could also potentially provide some information to you around licensed treatments or recommended treatments for COVID. But that's another source would be the FDA. And yeah.
Thank you. The point is that basically I've been in the ER and the hospital and the doctors and written and emailed them, and we're not getting any treatment. So anyway, I think I've said that, but I think it's important for everyone to know one, nobody encourages anybody to take a protocol to help stop, or if you get the virus. I mean, the only thing that's being talked about, of course, is vaccine, and it's shocking. It's shocking to me, but this is part of why I'm so serious. I'm on this commission because it's our job to make vaccines as safe as possible, and when we're talking about getting the COVID vaccine put it on the children's schedule, and at the same time we cancel a June meeting and then we postpone and then we don't have our board full, I think it is injustice to our children and to the people that are getting vaccine injured. This is not what I joined the ACCV to be part of, and it's a huge responsibility, and people are dying, and we're pushing off meetings, and we can't talk about things if we don't have a full board. I'm outraged about this. I know most of you know that have been on the meetings with me before, but there is no treatment. I know exactly what my parents were treated for, and it's basically my mom is at home dying actively right now. She hasn't eaten, and today's her 11th day, and my dad went into the hospital in a week. All they're doing is comfort care, and that's not a treatment, and that's it. Okay, so thank you. I appreciate that.
Yeah, this is Valerie. I'm so sorry for what you're going through. And I did want to say that FDA has authorized some monoclonals for treatment, but those monoclonals do need to be administered prior to severe disease. So I can provide some resources and information on those monoclonals.
I appreciate that, and we need to be providing that to all the doctors. This is the problem. I knew the minute I checked my dad into the ER, when they sent us home with absolutely nothing, I told her, I said, he's going to be back here and he's going to be dead in a week, and that's exactly what happened. So these doctors are afraid to prescribe. I talked to them in detail. I've talked to many, many doctors about this, and they basically say the FDA has not approved any treatment, and that's it. And they won't talk to me about the ivermectin. I sent this congressional report that was December 8th, 2020, And the one doctor, my dad's doctor, actually uses that as his protocol now. But, you know, it's too late for my father. And you know, my dad is old. My dad's 87 and my mom's 83. And, you know, but there's a lot of other people that are getting zero treatment, and we should all be outraged about that. We should all be doing everything
I'm sorry,
we can.
this is Valerie. I'm sorry. I did just want to clarify for the record that ivermectin, the FDA has not approved that for use in treating or preventing COVID-19 in humans. And it can, you know, cause, it's dangerous and can cause serious harm in humans. I just wanted to put that out there for the administrative record.
Well, and then I also suggest that everyone look at the 2015 where ivermectin, the doctor who started it, the two doctors, they were given the Nobel Peace Prize. So, you know, it's one thing to say that, you know, ivermectin might upset your stomach, or it's actually a very, very safe drug. It's a very safe drug. And when you have as many people dying as you do for something, if you give ivermectin immediately, many people get it. They get well immediately. So I think it's like everything else, that we have to be open to all cures. We can't say the vaccine is the only way. We cannot say that, because that's not true. And I do believe there will be a time, I'm not sure if I'm going to be alive, but there will be a time where people will look back at this time in history and it will be disgraced how we have treated humans, humanity. It's crimes against humanity. When we know that there's a treatment and there's a possible treatment when someone's actively dying or when someone's gotten COVID and do nothing, I've never in my life seen that. I mean, I understand the complexity of medicine and I understand that this is a money game and I don't believe it's a health game, but we should all be disturbed. We should all be concerned. We should all be doing everything we can do. And I promise you, if it was your family, you would go down and get the ivermectin, because you're going to take your family into the ER, you're going to take your family to the doctor, and they will send you home with nothing. This is what they say: come back when you can't breathe. So that's the fact. I'm not making this up. My parents are not any more important than anybody else who's dying from COVID. But because I'm on this board, I can't, with a conscience, not bring this up and tell everybody, you know, if it's your family member, if it's your loved one, if it's your child, everybody's going to look at things differently. And every human deserves a chance to be healthy, and they deserve a chance for medicine. So that's where I'm standing on this. And this is not going away, and this is going to continue, and more people will die until we can get active treatments.
So Karen, you know, we're sorry with what you're going through. And we'll send you resources that of other treatments that are approved from the FDA, from NIH. So we'll send that information to you, and that transitions to Claire. So Claire, you want to go and do your presentation, please?
Sure. I see Dana is asking to be unmuted.
Okay. So Annie, can you unmute Dana?
Yep, working on it.
Okay.
Can you hear me now?
Yes.
Okay. Yeah, just a quick comment. And again, Karen, I am sorry to hear about your parents as well. And I just had a close friend as well who has had a near-death experience with it as well. My comment is that, I mean, I work in an organization, and there's a protocol that if we do have people that are positive and to get treatment, and trying to get that as quickly as possible to then not see them be admitted and not have to be on oxygen and ultimately succumb to this terrible thing. But I also do comment just on record that we do see that there is a benefit with prevention. And so if we can get the prevention before we get that disease, that is obviously the ultimate goal. And so we're not even getting the COVID disease is really what our goal should be with that.
Thank you, and I absolutely agree. I absolutely agree. I think there's a lot of prevention that people can do, but I maybe I'm the only one, but I've never heard anyone, not one doctor, not one radio show, not any, I don't own a television, but I have not heard anywhere except for health freedom advocates talk about prevention. And this is something that we should all be doing. We should all be as healthy as we can be. I mean, children die of the flu. I think there were 3,000 people that died of the flu, but there's 250 children who have died from COVID. I mean, all we're doing as a society is talking about the deaths. It's like we're celebrating the deaths because we're pushing the vaccine. And so I agree, prevention should be up there, the most important thing. I got COVID in December. I almost died from it. I take my prevention. I take ivermectin. I take HCQ anytime I feel like I have symptoms. But these should be conversations that we are all talking about. And I think that everybody on this board and the other boards, this is something that we should be able to discuss. And, you know, we're talking about life and death. And I am absolutely pro-prevention. And, you know, but I don't ever hear that anywhere else. And so thank you, and I appreciate that for you making that public comment.
Okay, Claire, so you want to get started?
Sure, thank you. So I'm Claire Schuster, and I'll be presenting today's update for the National Institutes of Health. Next slide, please. I'll begin with an update about a phase 1 trial assessing the safety and immunogenicity of an investigational nanoparticle influenza vaccine. The vaccine is designed to provide long-lasting protection against multiple flu virus strains. This study aims to enroll 35 healthy participants 18 to 50 years old who will receive either a licensed seasonal influenza vaccine or the experimental vaccine known as FluMOS-V1. The study is being conducted at the NIH Clinical Center in Bethesda, Maryland. Scientists from NIAID's Vaccine Research Center and collaborators at the University of Washington developed the experimental vaccine to stimulate antibodies against multiple influenza virus strains. Universal influenza vaccines are being developed and tested by many research groups and could one day eliminate the need for annual vaccination by generating long-lasting antibodies to protect against many existing or emergent influenza viral strains. Next slide, please. So I'll be discussing COVID for the rest of the slides in my talk today, starting with RECOVER, which is an initiative from NIH that seeks to understand, prevent, and treat post-acute sequelae or health effects of SARS-CoV-2 infection. And this is also known as PASC. PASC is a term scientists are using to study potential consequences of a SARS-CoV-2 infection. RECOVER is asking research questions such as, what does recovery from SARS-CoV-2 infection look like among different groups? How many people continue to have symptoms after acute infection? How many people develop new symptoms after acute infection? What causes these health effects? And why do some people develop these health effects while others do not? For additional information, please visit the RECOVER website at recovercovid.org. Next slide, please. NIH has issued a Notice of Special Interest, or NOSI, on research to address vaccine hesitancy, uptake, and implementation among populations that experience health disparities. The overall goal is to apply scientific methods to promote the uptake of vaccination among groups that experience health disparities. Multiple NIH institutes and centers are participating in this effort. For example, the National Institute on Minority Health and Health Disparities recently made 5 awards for a total of $14.5 million over 5 years. NIAID and the National Institute on Drug Abuse have also made awards under this notice. Next slide, please. NIAID is supporting a phase 1/2 clinical trial in which adult volunteers who have been fully vaccinated against COVID-19 will receive booster doses of different COVID-19 vaccines to determine the safety and immunogenicity of mixed boosted regimens. The study is being conducted through the NIAID-funded Infectious Diseases Clinical Research Consortium, or IDCRC. The trial will include participants who've already received one of the 3 COVID-19 vaccine regimens that the FDA has approved or authorized for emergency use in the US. So that is the COVID-19 vaccines from Janssen, Moderna, and Pfizer-BioNTech. 12 to 20 weeks following their initial vaccine regimen, participants will receive a single booster as part of the trial. Currently, planned boosts include the 3 authorized or approved COVID-19 vaccines from Janssen, Moderna, and Pfizer-BioNTech, as well as Moderna's mRNA 1273.211 vaccine candidate, which combines Moderna's authorized mRNA 1273 vaccine and a vaccine candidate against the B.1.351 variant. People who have not yet received an FDA-approved or authorized COVID-19 vaccine are also eligible to enroll in this trial. The study has an adaptive design, which means that arms can be added as new vaccines are awarded EUA and/or variant lineage vaccines become available. We expect initial trial results this fall. Next slide, please. NIAID is also supporting a pilot study to assess the antibody response to a 3rd dose of an authorized COVID-19 mRNA vaccine in kidney transplant recipients who did not respond to 2 doses of the Moderna or Pfizer-BioNTech COVID-19 vaccine. Organ transplant recipients must take lifelong immunosuppressive therapy to prevent organ rejection, but this also blunts their immune response to both pathogens and vaccines. Research has shown that many organ transplant recipients do not develop antibodies against SARS-CoV-2 after receiving an authorized COVID-19 vaccine regimen. The purpose of this phase 2 trial is to determine whether a 3rd dose of one of the mRNA COVID-19 vaccines could overcome this problem for at least some kidney transplant recipients. The study is being conducted at Johns Hopkins University in Baltimore and will enroll up to 200 adults ages 18 years and older. Next slide, please. In May, Novovax initiated a pediatric expansion for the phase 3 clinical trial of its COVID-19 vaccine. The trial will evaluate the efficacy, safety, and immunogenicity of the vaccine candidate in up to 3,000 adolescents aged 12 to 17. Participants will receive either a vaccine candidate or placebo in 2 doses administered 21 days apart. A blinded crossover will ensure that all trial participants receive active vaccine. So this means that the participants who were initially assigned placebo will receive active vaccine later in the trial. Participants will be monitored for safety for up to 2 years following the final dose. In addition, a self-collected nasal swab study called SNIF, Swab Your Nose to Find Infection, is underway to assess the efficacy of Novavax's COVID-19 vaccine candidate among adolescents 12 to 17 years of age. The study will also assess asymptomatic viral shedding of SARS-CoV-2. Next slide, please. NIAID has launched a new observational study to evaluate the immune responses generated by COVID-19 vaccines administered to pregnant or postpartum people. In this study, known as MommyVax, researchers will measure the development and durability of antibodies against SARS-CoV-2 in people vaccinated during pregnancy or the first 2 months postpartum. Researchers will also assess vaccine safety and evaluate the transfer of vaccine-induced antibodies to infants across the placenta and through breast milk. MommyVax is being conducted at up to 20 clinical research sites nationwide through the IDCRC. Participants and their infants will be followed through the first year after delivery. And that concludes my talk for today, and I'm happy to take any questions. Thank you.
Okay, well, I have 2 questions or statements. This is Karen again. So I have read that pregnant miscarriages are up 320%. I'm not sure if those stats are exactly right, but I wanted to put that as a statement. I don't know if how the CDC is reporting that or looking at that? Or do you have any comments on that?
I am not familiar with the data. I don't know if CDC could comment.
Okay. And then my second question is about Anne Shot, that she's stepping down her assistant. Do you have any information on that? Because I've been reading a little bit about that, and I'm just wondering if you had any thoughts or comments on that.
She's also at CDC, so again, I'll defer to CDC for that question as well. Thank you.
Okay, thank you. Does anybody else have any questions? Okay, then I guess we'll move on to Valerie Marshall. She will be updating us on the Center for Biologics, Evaluation and Research, Food and Drug Administration, and vaccine activities. Welcome, Ms. Marshall.
Good afternoon. I am pleased to be with you to provide a brief update from the Food and Drug Administration. Next slide, please. The country has entered yet another wave of the COVID-19 pandemic. And the FDA is especially cognizant that immunocompromised people are particularly at risk for severe disease. After a thorough review of the available data, the FDA determined that this small vulnerable group may benefit from a third dose of the Pfizer-BioNTech or Moderna vaccines, and on August 12th, did authorize an additional dose in certain immunocompromised individuals, specifically for solid organ transplant recipients and those who are diagnosed with conditions that are considered to have an equivalent level of compromise. The age groups authorized to receive the additional dose are unchanged from those authorized to receive the primary vaccination series. And so for the Pfizer vaccine, that's individuals 12 years of age and older, and for Moderna, 18 years age and older. Just on yesterday, the FDA announced a virtual meeting of its Vaccines and Related Biological Products Advisory Committee to discuss the matter of additional doses of COVID-19 vaccines, and specifically to discuss the Pfizer-BioNTech BLA for administration of a third booster dose. And this meeting will be held on September 17th. Next slide, please. On August 23rd, 2021, the FDA approved the first COVID-19 vaccine. The Pfizer-BioNTech COVID-19 vaccine will be marketed as Comirnaty for the prevention of COVID-19 disease in individuals 16 years of age and older. The vaccine also continues to be available under emergency use authorization for individuals 12 to 15 years of age, as well as the third dose in certain immunocompromised individuals. FDA-approved vaccines undergo the agency's standard process for reviewing the quality, safety, and effectiveness of medical products. For all vaccines, the FDA evaluates data and information included in the manufacturer's submission of their biologics license application. Next slide, please. On August 13th, the FDA approved Tickle for active immunization to prevent Tick-Borne encephalitis in individuals 1 year of age and older. TBE is a viral infection of the brain and spine, which can be transmitted to humans through the bite of an infected tick. Although TBE is not endemic in the United States to date, it has been identified in more than 35 countries across Europe and Asia. US citizens, such as members of the military who are deployed to endemic regions, and travelers to those regions who engage in warm weather activity are also at risk for TBE. Next slide, please. On July 23rd, the FDA approved a supplement to the Biologics license application for zoster vaccine, recombinant adjuvanted, which is called Shingrix, to expand the indication to include the prevention of herpes zoster shingles in adults 18 years of age and older, who are or will be at increased risk of herpes zoster due to immunodeficiency or immunosuppression caused by known disease or therapy. Next slide, please. Here are some websites that might help you as we continue to remain informed about COVID-19 vaccines. Websites that you can view as your time permits. And that concludes my presentation, pending any additional.
Does anybody have any questions?
This is Dan Boyle. Can you hear me?
Yes, we can hear you.
Okay. I don't know if this is something I saw in the materials, but it has to do with the COVID vaccines, and I'm assuming they're covered under the countermeasures program. And when we talk about them being authorized for adolescents and then possibly in the future children, then they might fall under the vaccine table for children. Is that something that will be covered later, or just someone could clarify that?
So this is Tamara, Dan, and the countermeasures program is also administered in the division that I serve as the acting director. So the countermeasures injury compensation program, currently COVID vaccines are covered under that program. For a vaccine to be covered under the National Vaccine Injury Compensation Program, 3 things have to occur. First, it has to be, one of the things is that it has to be recommended for routine administration to children and or pregnant women. The second thing is that it has to have an excise tax imposed on it. And the third thing is that ultimately the secretary will issue a notice to add it to the vaccine injury table in the Federal Register. And all those 3 things have to occur for it to be covered. And so there is not an excise tax that has been imposed on COVID vaccines. So therefore, it doesn't meet all of 3 requirements to be covered under the National Vaccine Injury Compensation Program.
I see. Thank you.
Mm-hmm.
This is Karen. I have a question, because I know we're talking about doing the 3rd dose. And if we look at Israel, they're, I think, 85% vaccinated, but the vaccine is 39% effective. And so, of course, the question begs to be asked is how many vaccines are we keep giving if it's not effective, and we keep giving another booster, and then it takes that statistic of people that maybe got the first vaccine but don't want to get the 2nd or 3rd, and then they're considered basically unvaccinated. I mean, it seems, we have to keep talking about the stakeholder, because what I'm seeing is that this is causing concern for the stakeholder. I mean, people in my arena, we've been questioning this vaccine since day one, and but it seems like more and more people are saying, well, I did this vaccine and now I can get back to normal. That's not happening. We're going obviously in a reverse way. And then how many are we going to say, and when are we going to say that the vaccinated, the 85% of people in Israel that are vaccinated is only 39% effective? Is that the answer, to keep vaccinating? And you're the right person to ask that to.
So go ahead, Valerie. And then Annie, you probably want to like unmute Jonathan Duffy's phone too, to make sure. But anyway, Valerie, go ahead.
Yes, I was just going to add that, the FDA is reviewing all, the necessary data to make that evaluation regarding the booster doses. So at our upcoming advisory committee meeting, we will, outline discuss the data that is available and how best to proceed. Thank you.
Jonathan's line should be unmuted.
Okay.
It's showing.
Hi,
that he's-
yeah, I mean, I can add to that, I guess. So again, the conversation about the need for booster doses and who should receive those is still ongoing. And by conversation, I mean collection of data, review of data by the CDC's ACIP committee. So, again, no formal recommendation has been made for booster doses at this time, but there's the anticipation that there may be a vote by the ACIP related to that information in the near future. So, I mean, the current discussion is around whether there's a need for a third dose and who might benefit from that. And I think, one important point has been made that the discussion around a third dose does not necessarily imply that additional doses beyond that would be needed. And so obviously information is being collected and a lot is being learned about, the effectiveness of these vaccines, and CDC has published several reports recently looking at effectiveness. And I think, one key point that is differentiated is there's sort of effectiveness between any type of infection, which can include asymptomatic or mild infections. And then, so efficacy may be lower in some of these studies for those outcomes. But most of these studies have shown higher efficacy for preventing a severe infection, which includes hospitalization and death. So, again, the benefits of vaccination are in relation to the specific outcomes that are being studied. So again, I would just say that, there's continuing to be information collected, and more information will be put out when it's available and more recommendations in the near future.
Thank you. And this comes at the same time where, so many areas like New York is shutting down. There's places in my little tiny town that you cannot be in without a vaccination card. And what does that mean now? You have one vaccine. But I have to say that, the stakeholder, I've never seen more people come to the dark side of questioning vaccines. I mean, I have many, many people that I talk to, and we're in Oregon, and I think many other states and counties. They're firing everybody if you're not vaccinated, and so there's 11 people in the fire department that are leaving their job and protesting. And of course, I talk to the fire department because they're at my house every other day when I call 911. Before, my mom fell like 4 times, and so I talk to the fire department all the time, and all these nurses, so it's hard to hear that the CDC is still researching it at the same time that states like Oregon and California are making people leave their jobs without having these vaccine cards. And and then at the same time, well, 1 vaccine is not enough, and 2 vaccines are not enough, and so this is such a critical time for everybody because businesses are being closed down, people are losing their jobs, and to go to the website and say, well, maybe we're having this conversation. I mean, it continues to be that circle that these laws are being in place, people are losing their jobs, and we're not really sure if the third dose is even effective, or the first or second dose if you look at Israel. So I think that these discussions need to be had. I mean, this is a very critical time in history where people are losing their livelihoods, and we're not talking about prevention, we're just talking about another vaccine. We're not opening that gateway so doctors can have other treatments to actually see if that works. I mean, this is such a complex time. But thank you for your response.
So we can move on to Dr. Kim from the Office of Infectious Disease and HIV/AIDS Policy.
Well, thank you so much, Tamara. I echo others' sentiments in conveying my condolences to you, Ms. Kane, regarding both your parents. Truly unfortunate. I am so sorry. I do want to take this opportunity to make a couple of observations before we proceed with updates from the Office of Infectious Disease and HIV/AIDS Policy. Regarding pregnancy, you've asked questions about pregnancy and COVID-19. The clinical trial, the clinical phase 2-3 trials for the messenger RNA vaccine for the Pfizer from Pfizer indicated that there are no increased adverse events associated with the vaccine among pregnant women. So including issues like miscarriages and spontaneous abortions. The vaccinated group versus the placebo group, there was no difference. And additional post-marketing studies on all of these vaccines are really robust in making observations on any complications related to pregnancy. And thus far, all the evidence indicates that the potential harm from COVID, the disease itself, far outweighs the possible adverse events that might be associated with the COVID-19 vaccine, the messenger RNA vaccine, specifically in this case. So for all pregnant women, for age appropriate, the recommendation is that age appropriate vaccination should be done to prevent COVID-19. And you mentioned earlier from Ms. Payne about the need for prevention for COVID-19. Absolutely, you agree with that assessment, and I can't agree with you more. And the best mode of prevention that we have, the best tool that we have in our arsenal, as little as it is at this point in terms of intervention, there is a huge tool that's currently available, and that's the COVID-19 vaccine. And it is recommended that unless there are specific contraindications, that people 12 years of age or older get the COVID-19 vaccine. That is by far, in a way, the most effective way to prevent COVID-19 and also to prevent the spread of COVID-19 in our communities. So with that, let me go ahead and get things set up for the Office of Infectious Disease and HIV/AIDS policy updates. I am pleased to introduce Deshawn Dade, who is a public health advisor in the Office of Infectious Disease and HIV/AIDS policy, who will represent OIDP in ACCP meetings in the future. So I am going to turn the podium over to Mr. Dade to provide updates in our office. And I appreciate this opportunity for us to have this conversation on safety of COVID-19 vaccine. John? I think you might need to be unmuted.
Yep,
Yes.
we'll work. Yep.
He should be.
No, he's not. I see that he's not. It's still showing he's muted.
Hello,
Yep.
Can everybody hear me?
Yes, now we
Okay.
can.
That's good. Thank you for the introduction, Dr. Kim. This is my first ACTV meeting, and I'm super excited to share with you the latest updates within OIDP as it relates to our vaccine portfolio. Next slide. I wanted to start off by first talking about the National Vaccine Advisory Committee, which convenes 15 members 3 times a year to provide recommendations and develop reports intended to further the goals set forth by the National Vaccine Plan. In 2021, NVAC has met twice and has an upcoming meeting scheduled in September. The first meeting of the year was held on February 4th through the 5th. During day 1 of the meeting, NVAC members discussed barriers to receiving the COVID-19 vaccine, which included an enlightening presentation on how the fear of vaccine needles can lead to vaccine hesitancy. During day 2 of the NVAC meeting, the focus shifted to vaccine safety. Representatives from VRBPAC, ACIP, and ACCV gave updates on vaccine safety. The second NVAC meeting was held on June 16th through the 17th. Dr. Rachel Levine, the Assistant Secretary of Health, provided opening remarks and outlined her priorities as it related to vaccines. During the meeting, NVAC members heard from various organizations on how they are working to address vaccine equity and vaccine hesitancy within their communities. The meeting also highlighted the need for children, teens, and adults to get caught up on routinely recommended vaccines which were missed during government shutdowns caused by the COVID-19 pandemic. During this June meeting, NVAC members approved an immunization equity report, which outlined 23 recommendations to the Assistant Secretary of Health which can advance vaccine equity within our nation. The report addressed equity as it relates to access, affordability, knowledge, awareness, vaccine acceptance, and data tracking. The third INVAC meeting is scheduled to take place on September 14th through the 15th. The panel will be on COVID-19 vaccines, rapidly advancing science of mRNA vaccines, and there will also be presentations on how organizations are preparing for the upcoming flu season. Next slide. The Vaccine Division is currently in the process of implementing the 5-year vaccine plan, which was created in January of 2021. This plan and the activities within the National Vaccine Implementation Plan are needed to sustain and renew progress, address persistent and newly identified gaps, and to proactively respond to the changing vaccine landscape. To ensure the goals, objectives, strategies, and indicators within the plan are met by 2025, the Vaccine Division is currently in the process of engaging the Federal Interagency Vaccine Work Group, who serve as a steering committee who guide the implementation of the National Vaccine Plan. Since the plan was released in January, program staff have been working to engage and strengthen the partnership between IVWG and OIDP. To support this initiative, we have updated our IVWG roster, scheduled a meeting date to convene the IVWG on September 21st, and we also have recently distributed a steering committee letter to the IVWG members detailing the roles and responsibilities. We are also currently in the process of finalizing a data collection tool which captures which particular activities agencies will be conducting within the next 5 years to ensure the goals within the National Vaccine Plan are met. Once this data has been collected from the IVWG, the implementation plan will be drafted, and hopefully the final version will be available for publication between the months of January through March of 2022. Next slide. I'm excited to announce 2 community vaccine grants with the Office of Assistant Secretary of Health. The goal of these grants is to increase vaccine uptake by working with local communities to increase vaccine confidence and access to routinely recommended vaccines. The Promoting Vaccine Confidence in Local Communities through partnership with regional health offices is due to begin on September 30th. Applications are currently being reviewed by an evaluation panel to determine 6 to 8 organizations who will be awarded funding for the next 3 years to increase vaccine confidence within their local communities. To accomplish this task, selected awardees are being asked to complete the following objectives through the project period. They will first have to identify a community with low vaccination rates caused by a lagging of confidence in vaccines. Once they have gained a better understanding of the vaccine landscape within their community, they will have to design an intervention strategy to erode vaccine hesitancy specific to that target population. This intervention should be evaluated throughout the project period and modified as needed based on the outcomes found within the data. The overarching goal of this project is to leverage the work done by these organizations so it can be shared and replicated among communities facing similar vaccine confidence issues. The second grant opportunity I want to share with you today is an innovative approach to enhance the immunization culture in OBGYN care. This is a joint partnership between OIDP and the Office of Women's Health. The goal of this project is to promote and strengthen immunization culture within OBGYN offices, family practices, and birthing classes. Engaging future parents in these settings allow for greater discussion about the importance of prenatal vaccinations, such as Tdap and the flu vaccine. In addition, this allows the physician to start the discussion with expecting mothers on the importance of getting their newborn child vaccinated. The selected sites for implementation of this project were determined by the amount of non-medical kindergarten exemptions. The top 14 areas with the greatest non-medical exemptions have been targeted for project implementation. Next slide. I wanted to speak briefly about the importance of getting children, teens, and adults caught up on routinely recommended vaccines, which were sorely missed due to the COVID-19 pandemic. Due to the government shutdowns caused by the COVID-19 pandemic, many children and teens missed their wellness visits, which include receiving their immunization. According to a study, an estimated 26 million doses were missed by children and teens during the COVID-19 pandemic. As Americans once again congregate in large groups, the presence of non-COVID-19 diseases such as influenza and pertussis may increase, especially if populations are not up to date on routinely recommended vaccines. With the presence of unvaccinated populations, this can lead to a greater chance of the spread of vaccine-preventable diseases, leading to increased illnesses, hospitalizations, and sometimes even death. Next slide. To address the need for catch-up of routinely recommended vaccines, the vaccine division is working closely with the communication division within OIDP to promote the importance of catch-up vaccinations, especially among children and adolescents who are returning back to in-person learning. In observance of National Immunization Awareness Month, which occurred throughout the month of August, OIDP promoted vaccinations and adopted the National Immunization Awareness Month theme, which is to get back on track with routine vaccines. To promote and engage stakeholders, OIDP utilized various social media platforms such as Facebook and Twitter to bring awareness to this issue. We also created a Catch Up to Get Ahead toolkit, which contains information on how to increase access to vaccination, coordinate communication, and how to utilize policy to reduce barriers to obtain delayed vaccinations. Lastly, we compiled an inventory of catch-up activities being conducted on the national, state, and local levels and posted these efforts on our HHS vaccine webpage. And that concludes my presentation, and I'm open for questions. Thank you.
Thank you, Dr. Kim and Mr. Dave. Does anybody have any questions?
This is Dan Boyle. Sorry, go ahead.
No, go ahead, Dan.
You mentioned the vaccine safety and innovation meeting September 14th and 15th. Is that open to the public?
I think it is. David, would you comment on that? I think it is, but I'm not sure.
I am not sure either.
I can find out for you, sir, and get back to you and let you know. I can also send a link to the index if needed as well.
Thank you.
This is Karen. I do believe that they are open to the public. I have, of course, a couple questions and comments. One, it seems today that we're coming to an end that no one's really talking about shedding. You know, I know that Dr. Kim, you talked about the best way to prevent COVID is through immunization, but, you know, again, referring back to Israel, it's only 39% effective, and then that we have these new Delta variants. And, you know, of course, there's much talk about that being the shedding from people who are vaccinated, and that's a real thing. I know many people who have caught COVID from being around someone who's vaccinated. I know a lot of people who have had the vaccine that are getting COVID, and you know, this again goes into the question about the stakeholders, because these people are doing the dutiful thing, the thing that our government has told them to do. They're doctors and getting, you know, vaccinated and also being sick. It's hard for me to not look at a lot of the presentations, and they're all amazing, and thank you everybody. But we're, you know, people are kind of talking about, wow, we're having more meetings, we're on this, and at the same time, the ACCV board in March, information that I wanted to discuss in March was pushed off to June, and that June meeting was canceled. So it's hard for me to feel very proud about the work that's been done in 2021 on the ACCV board, because I feel like there's been a year that we've not been staffed fully, and then we're postponing. So, and I feel again that this is such a critical time in history. And so I would like to know, because, you know, there was talk about that there's many doses of vaccines that aren't being given. So I'd be curious to ask you, Dr. Kim or John, what are the statistics of the SIDS? Because, you know, are the SIDS cases going down at the same time the vaccine rates are going down? And I think this is an appropriate question for the ACCV board, because our job is to make vaccines safer. And so to look at this type of statistic, I think is very telling and very important. And then are we having any of the other diseases on a rise? Because obviously the only thing that anyone is ever talking about is COVID. So I'd be curious to know, one, if CIS cases are decreased during this time, because I think we've addressed this a couple meetings ago, it seems like forever ago. And then two, are there any other diseases that are on the rise currently, and what are the stats on those?
Wow, this is David Kim. I appreciate all those questions. Quite a few questions you posed, but the ones related to the operation of ACCV, I'll defer to ACCV administrators. But regarding some of the other questions, if I can call them correctly, one about COVID-19 cases among kids. Yes, indeed, rates of infection among kids are rising, and predominantly among kids who are not yet authorized to receive any vaccine. Now, you mentioned case counts going up, meaning cases of infection. The vaccines, all three COVID-19 vaccines that are currently licensed in the United States are designed, or the clinical trials have mainly focused on not their ability to prevent infection, but their clinical efficacy has been looked at very carefully. So, are they preventing disease? Are they preventing hospitalizations? Are they preventing severe disease where people need respiratory support? Or do they prevent deaths related to COVID-19? And the answer to those questions are absolutely. And the vaccines, despite the Delta variant cropping up and basically taking over the disease burden in the U.S. and elsewhere, that the vaccine is working in preventing hospitalizations, preventing severe disease, and preventing deaths. Now, as far as infections are concerned, some of these are breakthrough infections, and no vaccine is 100% effective in preventing infections or even preventing hospitalizations and others. So there are breakthrough cases. So we can't lump them all together and say vaccines are not effective, because they are effective in preventing severe illnesses and deaths. So the science coming out of Israel, that is an evolutionary process. They are basically ahead of the U.S. in terms of their vaccination program, and we are learning a lot through their experience. Now, the data coming from the U.S. are being analyzed by CDC on an ongoing basis, which also takes into account the studies coming from Israel, the study coming from UK and elsewhere. So the data that we currently have, still, bottom line is still that the vaccines work in preventing the disease. And I would defer to Dr. Duffy in terms of any study specifics, but if you're talking about studies on ivermectin and so on, I have not seen clinical trials related to the use of ivermectin in either preventing or effectiveness in treating COVID-19. So unless there are clinical trial and other data related to that, I will defer to the FDA expertise in identifying the treatments that have been proven to work and prevention modalities that have been proven to work that allowed emergency use authorization or biological licensing.
Thank you. And am I right in saying that the deaths of children, because I know that there's a lot of talk about children getting COVID, but I think the rate of death is 0.1% of deaths in children currently?
You know, I represent the Office of Infectious Disease and HIV/AIDS policy. I would defer to CDC for up-to-date responses on specific data concerns.
Okay. Thank you so much.
And this is
Does anybody
Dana.
else have-
Yeah, this is Dana. Just want to make it a comment too about the study, Karen, that you discussed in Israel with the 39%. I do want to say that the vaccination, though, has shown that it is highly effective against severe disease. So 88% against hospitalization and 91% effective against severe illness. So definitely we have seen some benefit with that. And clearly the hospitalizations that we have seen and ICU and ventilations within the United States has been higher in unvaccinated individuals.
Thank you. And you know, and I have to say, I believe a big part of that's because we're not offering any treatment, which has been my experience. You know, I think that there are things that we can do, and I think that this should be a time where we look at experimental information. But thank you, Dana. Appreciate that.
So Karen, that was our last presentation. So now we're moving on to public comments. So Amber, you want to open it up and see if there are any public comments?
Yep. So if you have a public comment and you are on the telephone, please press *9 to alert us that you'd like to make a comment. If you are on the web platform, you can use the reactions button on the bottom right-hand side of your screen to raise your hand, and we can unmute you for your comment. So I'm not seeing any requests yet to make a comment. Did you want to wait maybe another minute or so? I know that this is a new platform for the ACCV.
Okay, it seems like there aren't any comments, so we can move on to future agenda items.
Does anybody have any future agenda items besides myself?
This is Dan Boyle. I don't know if this is a question or maybe for a future agenda item, but in reviewing some of the materials and the orientation, I discovered CISA, is it CISA, Center for Immunization Safety, but I was very curious about it because in helping people make the decision about getting immunized and those that have some high risk, often I would read the high risk had to do with immunocompromised or allergic. But for those that have been injured by vaccines in the past, making the decision about new vaccines, it's especially highlighted during COVID, and that I wasn't quite clear, even going to the website, just how it works. It looked like it was accessible through a provider, not necessarily the person, or maybe the person, it wasn't clear. I think from just a practical point of view, to have information about that and how that works and how it's serving people that have been injured or maybe are concerned about injury and their particular medical condition going into COVID. In my personal experience, one of the provider I brought the issue to said, there isn't an answer to my question, but here are some resources. There were articles that left it back for me to weigh.
So, Daniel, are you seeking more information about how CISA works in a future meeting, or Jonathan can give you information, could kind of provide you more information now? Just trying to understand your request, your ask at this point.
Yes, I didn't see it in the presentations. I might have missed it, but it was something I'd seen in some of the materials in preparing for the meeting. And so I had those questions, but there might be more to it than that.
So Jonathan, do you want to share some like a quick overview about CISA with Daniel?
Yeah, I mean, you mean now, or you mean at a different time?
Now, just so he can understand. Kind of, if you could just provide a few some information about it, just so he understands how it works initially, anyway.
Sure. Yeah. I mean, CISA is the Clinical Immunization Safety Assessment Project. So I think there may be other things that use that acronym as well, but in the context of CDC and vaccine safety, that's what it refers to. So this is one of CDC's Immunization Safety Office, one of our three main projects. And it's basically, it was established in 2001. And it's a collaboration. It's funded by the CDC, but it's a collaboration with 7 medical research centers. So it serves several functions. One is to do research on vaccine safety, but one of the other functions is to provide clinical consultation. And so, yes, that's a consultation that is provided to healthcare providers or health departments in the United States. So it's not something that a patient or a vaccinated person would access directly. So, I mean, even if a healthcare provider had a question about their own health, they would have to have a healthcare provider treating them. And then that healthcare provider could contact CISA and request a consult on their case. And so the basic process of that is that the CISA investigators will review the information provided about the case, and then they'll review information that's available in the literature from other data sources, such as VAERS or VSD, the other systems that CDC operates, and basically provide a consultation. And so, when there's evidence available from previous research, that's relied upon. And like, I think, as you said, like sometimes not every question is something that's specifically been studied, or maybe unique aspects to an individual person or case. So in those cases, they rely on sort of expert opinion of the CISA investigators who are, represent a range of medical specialties and scientific disciplines, and they can draw on outside expertise from other medical specialists as needed. So that's just a basic overview, and that's something that I can either send you more information about, or I'd be happy to provide a more detailed overview presentation in the future.
Thank you. And I bring it up too as from my own history of searching out information for myself since the injury, and including up till recently, in terms of decision about vaccines, and the importance of this kind of information, or the availability of this kind of consultation, not only about the vaccine itself, but also about once a person is identified, either self-identified through VAERS or their provider identifies them, that we find those, that we have detection systems that find those people that have been injured, and then the whole second step about what to do then. And so that was part of my question, and I'm going to be interested to hear more about that part of it in the future. if it's a vote. Thank you.
Thank you. Is there any other new business? Okay, I have 2 items for new business. Can anyone hear me? Like I'm in a zone. Okay.
Yeah.
Okay. Thank you. So I will start here. This is not exactly new business, but it falls under new business, and obviously everyone has, except William is new today. So I will start here. At the December 2020 meeting, I proposed under new business to invite Dr. Mawson to present and discuss his vaxxed versus unvaxxed research published studies. Dr. Mawson is a pro-vaccine epidemiologist and is committed to finding the safest way to keep children up to date on their vaccinations. In the December 2020 meeting, the board had 4 members who all voted to invite Dr. Mawson to talk and present at the March meeting. My goal was to form a work group to discuss in detail the vaccine safety data link, the VSD, and how HHS can use it to create safer vaccines and look at vax-unvaxxed studies that have been done by numerous people. Days before the March meeting, I was asked to postpone Dr. Mawson's presentation due to the lack of commissioner staff. I hesitantly agreed, which now I regret. It was never discussed at that time that Dr. Mawson's certifications, studies, or specialty was in question. It was just stated that there were not enough members to have this conversation. Just a few days before the June meeting, that was canceled. This is during a time in history that we have never experienced before with the push of COVID vaccines for children, which will eventually, my guess is, become under the National Vaccine Injury Compensation Program. It is my opinion that the responsibility of the ACC board has never been more important. As I prepared for the September meeting, I was informed that the ACCV board's vote and wishes were being rejected and Dr. Mawson would not be able to present his research at this meeting. This is 9 months after the actual vote took place. It is my understanding that, and Mrs. Overby phoned me, we had a conversation with Annie, and I was informed of that conversation just weeks ago that Dr. Mawson would not be allowed or invited to present. And it is my understanding that Ms. Overby's job is to support our agenda and decisions and votes as a commission and not override them. Over the phone, I was told that Dr. Mawson was not specialized in this field. His reports were retracted, and it was also mentioned that I did not give the board enough time to evaluate the information. Those were the 3 reasons that I was given that Dr. Mawson will not be allowed to present. After asking Ms. Overby twice for her reasons in writing to reverse our vote, I received a reply yesterday morning, and this is why I dumped all of that information to everybody last night, because I actually was flying to California because I'm speaking today at Autism One. I have to say that I find it ironic because I have had my hands slapped for sharing information just before the ACC meeting, not giving it time for people to digest information. During the conversation on the phone that I had with Ms. Overby, I was told to look back at the minutes, and I did just that. And I found that the minutes from the December ACCV meeting do not include the vote. They have been removed or just not included. I have included in the email yesterday to everybody a link to the vote in question. It's an audio link, and it is at the 2-hour, 57-minute mark where I talk and I bring to the table asking for the Vax study. The actual vote is at the 3-hour, 21-minute mark. I find the fact that such an important vote was removed from the minutes shocking and irresponsible, and part of the bullying that I've been experienced as a parent commissioner on the ACCV board. And so I'm going to just summarize, which is not that short, the December 2020 meeting and my proposal, because I feel like it needs to be done again. We have all new board members. So here's my summary. It is part of the description of our duties from the ACCV charter that the committee do our best to ensure that vaccine products result in fewer or no significant adverse reactions. To quote our functions of duty under item 4, survey federal and state and local programs and activities relating to gathering of information on injuries associated with the administration of childhood vaccines, including the adverse reaction reporting requirements of Section 300 AA-25B of this title, and advise the Secretary on means to obtain, compile, publish, and use credible data related to the frequency and severity of adverse reactions associated with childhood vaccines. As commissioners, we may not all agree on the safety of vaccines and the schedule. Our responsibility is to make sure that the children who are injured are compensated for their injury swiftly and fairly. If you are pro-vaccination, you must be pro-compensation. To properly compensate those who are injured for the greater good, we must have appropriate information on the science. I believe this is our ethical duty as ACCV members. The reasons the ACCV committee should look into doing a vax versus unvaxxed study are below. In 2019, the World Health Organization declared vaccine hesitancy as one of the 10 biggest threats to global health. Currently, no one knows the risk profile with any scientific certainty on the current vaccine schedule. The schedule has never been tested together as it's recommended today by the CDC. There has been a threefold increase in vaccines compared to the 1983 schedule. This is before the 1986 Act was put in place. In 1980, chronic health in children was at 12%, with 10 vaccines given. Today, 69 doses of 16 vaccines are given, and the chronic health in children today is at 54%. The safe levels and long-term effects of vaccine ingredients such as adjuvants and preservatives are also unknown. The IOM has stated that studies were needed to compare health outcomes of vaccinated and unvaccinated children to include the timing, age, and load given at one time. A major current controversy is the question of whether vaccination plays a role in neurodevelopmental disorders, which broadly includes learning disabilities, attention deficit, hyperactivity disorders, and autism spectrum disorders. And I just want to add here, Dr. Monson is completing a study specifically on that information. The 2012 IOM report highlighted the key gap in safety science being the lack of public data comparing health outcomes for fully vaccinated versus unvaccinated controls. Even the CDC has conceded this gap in safety science. Parents have been voicing concerns about safety of the recommended immunization schedule as a whole, with opinions that children receive too many vaccines at too young of age and that early childhood immunization overwhelms the immune system. This is from the white paper on the safety of the childhood immunization schedule vaccine safety data link from 2015. The IOM has complained multiple times about the gaps in safety and limitation in knowledge on vaccine safety, that few existing studies are too small or have inadequate length of follow-up with no reasonable chance of detecting true adverse reactions. In 2012, the IOM Adverse Events of Vaccines, Evidence and Casualty report highlighted the key gap in safety science is the lack of public data comparing health outcomes for fully vaccinated versus unvaccinated control. The childhood immunization schedule and safety. Stakeholder concerns, scientific evidence, and future studies from the IOM in 2013 identified the lack of baseline data on health outcomes of unvaccinated children as a key gap in safety science, making any science-based statements as to the safety of childhood schedule impossible. The IOM Infant Schedule Study Committee concluded in its 2013 report that few published investigations have specifically examined the safety of the recommended childhood schedule as a whole. The IOM report also highlighted 4 research questions of the highest priority to stakeholders. Number 1 was, how do child health outcomes compare between fully vaccinated and unvaccinated children? Vaccination policy in this country depends upon trust between the people and the regulatory authorities. In closing, American taxpayers pay $90 million a year for the vaccine safety database. The VSD was created with the express purpose of analyzing vaccine safety. The VSD enrolled over 9 million children from the 6 NTOs. It is our job as commissioners of the ACCV board to explore the use of the vaccine safety data link to help compensate the injured fairly. We can also use it to track healthy children, and using the vaccine safety data link will help the hesitant stakeholders to trust the hypothesis. Today, again, I'm asking for the ACCV board to create a work group to look at using the vaccine safety data link to gather information and to have discussions about the best ways to make vaccinations safer and as safe as possible, including talking about Dr. Mawson's unvax studies. And once again, once we gather all the information, then we can decide to go forward. I also emailed you numerous things. I emailed you the audio that talks about basically where we all voted to have him speak. I emailed you Dr. Mawson's questions that were asked over base, and he has answered them. I emailed you his CV. I emailed you, I can't remember if it's 24 unvax studies, and I know there's a lot of information. I'm excited to work with the new commission, and I think that it is our responsibility to at least give this a look or have a conversation about the BSE being used and talking about just having the conversation about a unvax study. I would like Dr. Mawson to be able to address him being kicked off as a speaker, because I believe that he has answered all of the questions and everyone could read that. And then maybe we should have a vote on that. But I don't believe that as the commissioners, as we have voted on, go forward for something to be retracted, that it's privately and done, just weeks before this meeting. I find that very challenging as a commissioner. And I just want to remind everyone that the congressional goal of the 1986 Act was to fully compensate those who were injured by vaccines. If we ever err, it should be on the side of taking care of the injured. And I believe this is an important part of performing our charter. And of course, I'm passionate about this because my daughter has gone through this program, and so I see what happens. I would like to have the charge work with epidemiologists, more than one. I would like to have a group of people. I would like to look at the effective ways to use the vaccine safety data link to ensure that vaccines are as safe as possible and to help the injured be properly compensated. I would like to explore the history of the unvax studies, which I sent to you. I'd like to explore the reasons why we need a unvax study. I'd like to create a method and create a design. And my hope, this is just coming from me, a parent, I would like to have a 10-page report ending with recommendations. The work group will invite outsiders to assess that we send to the Secretary of HHS. And once we have heard Dr. Mawson present, I'm hoping that we can still have him present, or another epidemiologist. I suggest that work group look at the 40 studies, pick the best 5, and look at them more closely. I believe this is an important time that we have these conversations. I would like to invite outside consultants to help with the work group. And with its charge, I also want to invite Christina Campilillo, the VIP bar, to present a brief report on why this data is essential both as required by Congress and the proper functioning of the program to achieve the congressional goal. I would like to invite HHS to discuss their 2 IOM reports regarding the unvax study. And that is where I stand. And so I would like to invite new members to take a vote to have this conversation at another time or in a work group, and to talk about Dr. Mawson coming back to present.
So Karen, so what specifically is your ask of the members at this point? Because you've said a couple of different things. So because ultimately before you were thinking about just sending a recommendation to the secretary to encourage HHS to conduct or either to fund a study of vaccinated versus unvaccinated populations. It would just been a recommendation to the secretary. That was I thought the goal before. So is that still the goal?
Well,
Your
I think
goal?
that there's many goals. I think there's many goals when we open up this conversation. I think it includes looking at the unvax studies, and I think part of that would be looking at the VSD to create those studies and to have the lawyers.
So Karen, that this commission doesn't create studies. That's not the role of this commission. This commission does not create studies. So that would not be possible here in the commission. We don't create studies. We make recommendations for studies to be conducted. And that recommendation, you're making recommendations to the secretary. This committee doesn't conduct studies.
Okay, so we can make recommendations after looking at the studies to the secretary about using the vaccine safety data link to have access to that and to talk about Dr. Mawson's vaccine back studies. And there's 40 vaccine back studies. I mean, I could name many, but Dr. Mawson is a pro-vaccine scientist. He's pro-vaccine. He's just doing studies. And so I sent everybody. You had a bunch of questions for him. He has responded yesterday.
This is Dr. Holloway. What part of this is in the scope of what we're supposed to be doing?
So Dr. Holloway, in the charter, there is a, and I will have to pull it up, but there is a section about advising. Let me just pull it up. So there is, let's see here, it's number 4, survey federal, state, and local programs and activities relating to gathering of information on injuries associated with the administration of childhood vaccines, including adverse reaction reporting requirements, and advise the secretary on the means to obtain, compile, publish, and use credible data related to the frequency and severity of adverse reactions associated with childhood vaccines. So it's not here that we conduct studies. It would be that this commission could send a recommendation to the secretary to encourage the secretary to fund or conduct the study that Karen is recommending. So that would be the role of this commission, is just to send a recommendation, but not to actually do to actually conduct some type of study.
And she's asking to do a vaccinated versus unvaccinated study?
Yes, that's what Karen.
No, what I'm asking to look at the vaccinated versus unvaccinated studies and invite Dr. Mawson to present his information so we can as a group talk about the vaccine safety data link and talk about vaccine back studies and make a recommendation to the secretary on, about using this, giving him information and why this should be open to us and why people should be able to use it.
So Karen, so Karen, there are 2 different things you're talking about. You're talking about using the vaccine safety data link, which is just it is a data set. That data set is open to individuals. And then there's a separate issue of making a recommendation to the secretary about conducting some type of vaccinated versus unvaccinated study, which could be any data set. It could be a clinical trial. So you're talking about 2 separate issues here about accessing VSD, and then also about recommending a vaccinated versus unvaccinated study. So those are 2 separate issues about, so.
We have vaccine vaccinated studies. We have 40 of them. I'm asking the board to form a work group so we could look at those studies. So then we can, with that information, because this is a conversation we've never been able to have. Obviously, it was pushed off in March. June's canceled. It was canceled from this meeting. Dr. Mawson should have been presenting today because he was voted in to present today. So I'm asking that we have Dr. Mawson come in and present his studies, and from there, form a work group so we can look at the most effective ways to keep vaccines as safe as possible. And along with that, it pretty much is parallel, and he'd like to do 2 work groups, I'm fine with that, is looking at the vaccine safety data link and how the Vaccine Injury Compensation Program can use that to properly pay the children who are injured. So if we want to put that into 2 work groups, I'm happy to do that. But both of those are very critical, and providing compensation for the injured and addressing vaccine injury. So we can, we're supposed to be making, recommendations to the secretary about how to keep vaccine safe. And both of these fall under that.
So Karen, in the vaccine injury compensation program, our medical staff on a regular basis do look at the literature, published literature, peer-reviewed published literature to make decisions about our own compensation. So it's not that we need to look at VSD. If there's a VSD study that has been produced and it's based and it's a peer-reviewed scientific literature, we review that on a regular basis. So we do that on a regular basis. So there's not a need for us as program officials to be encouraged to look at a VSD, because if a study was published based on VSD data or some other data sets, we do look at that on a regular basis. I mean, we're looking at it every day. So
I'm asking
yeah.
that the attorneys that represent the families of the injured be able to use that information. It's not just simple for you guys to have that information, but the attorneys that are representing the children that
they do have access. They have access
allowed.
to the public. They have access to the published literature just like we do. We only have access to published literature resulting from VSD or some other type of data set. But then in my understanding, and then Jonathan, if you can chime in too, the VSD is available. They do provide or allow that data to be used. So Jonathan, can you, if I'm wrong, please check, please clarify. Yes.
Yeah. So, I mean, the Vaccine Safety Data Link is, again, a system funded and coordinated by CDC. So I think there's two pertinent mechanisms. One is for, studies that have been completed. There are data sets that exist. There is a formal, data access program, and information about that's on the CDC website. And then, there's also the option and a set procedure for if people have study ideas for using the VSD data, they can partner with, one of the participating sites or an investigator to propose that idea, and then it would be reviewed using sort of standard procedures for doing that. So there are those options currently available.
And the VSD is not open to the public for doctors to access, and it's not open to the attorneys so they can actually help win the cases of the children. So there's a lot to the VSD. I understand it's complicated, and I understand this is a conversation that nobody wants me to have, but this is a conversation that we need to have, and it goes farther than that, because it's not just open to the attorneys. And it's, studies have been made, but it's not accessible, and you can't just go in and use it. Like, you can do a study, you can go to VAERS and you can run any kind of report about the VAERS information. That's available, but you cannot do the same thing with the VSD. And so we can discuss that later, but it's not just accessible to anybody who wants to use it. It's not accessible to the attorneys. It's not accessible to the parents, the families of the vaccinated, to compare vaccinated and unvaccinated. So it really does tie in, because if you use the VSD to run a vaccinated and unvaccinated study, it's a totally different thing. We have access to studies that have already been done. But I think opening up this conversation, talking about these reports, I think the commissioners might be interested to take that a step further once we can have that conversation. But so far this entire year, I've been unable to bring that conversation to the table to the commissioners.
So Karen, what are you asking other commissioners right now? You want them to form a work group to discuss, recommending to the secretary to have a vaccinated versus unvaccinated study?
There's 40 vaccinated versus unvaccinated studies. So I'm not asking for a study to be done. I'm asking for Dr. Mawson to be able to come present and talk about his findings.
So my question, this is Dana. Can he not be part of the public comment? Wasn't that an opportunity for him to say something? I guess this is obviously new to me.
So Dana, generally we have public comments when things are on the agenda. So
okay.
So that's one thing. And then we do have his information. Karen just sent a bunch of it out yesterday about his study. So you can read that to find out about his studies. So I'm still trying to, so Karen, so you're asking to form a work group. Is that what you're requesting that the members consider doing now?
I'm asking for Dr. Mawson to come at the December meeting and present his vaccine back studies. That was the vote that we voted all on at the December 2020 meeting. And we all agreed to have Dr. Mawson come talk about his vaccine back studies in public. And from there, I would like to create a work group.
Yeah, so the purpose of that was, my understanding back then was to inform this recommendation around a vax and unvax study, but then you're saying, no, you don't want to recommend that a vax or unvax study be done, right? I'm trying to.
You just told me that you just told me as a commissioner I could not do that.
No, I said you can send a recommendation to the secretary for a vax or unvax study. I said,
okay.
the ACCV does not conduct the studies. We don't conduct the studies.
I understand that.
The ACCV can send a recommendation to the secretary for that purpose.
That's exactly
if the full ACCV agrees to that.
And we did. We actually did agree to that in December, but you took that off the table. We all agreed on that, and that's my whole point. That as commissioners, it is our job to work together and to decide what to do. And you in your position took that off the table, and I don't believe that's correct.
Karen, I'm still trying
to support our decisions.
So Karen, I'm trying to understand, what are you asking today? You just so you're asking to have Dr. Mawson present to what end? For what purpose?
For his purpose, for us to look at his vaccine back studies from their creative work group, so we can all look into see if we should do a vaccine back study with a vaccine safety data link, to ask the secretary to look at that, to use the safety data link, to look at Dr. Mawson's study, to have this conversation. This is part of our purview to make sure that vaccines are as safe as possible. And I believe and the Iowa has talked about it numerous times, that we should be looking at vaccine back studies. So this isn't totally out of the realm of information. I'm just asking, again, for this to be a public meeting, public record, Dr. Mawson come in and talk about his vaccine back study. My hope is that it will perk interest for the commissioners to agree to be part of a work group, so we can make recommendations to the secretary.
So Karen, that can be decided without him making a presentation. The group can decide today whether or not, or we can solicit. We can basically, we've had this discussion, and members can go back, especially since they're new. They can go back and think about whether they want to be a part of this work, a part of a work group, based on the information that was sent yesterday around Dr. Mawson, and they review that information, and then we can send an email, say, do you want to be part of a work group? And we can form a work group.
No, I want this to be public record. I want Dr. Mawson to have the opportunity to speak public record to everybody. I don't want to be in a private work group, because the history of the private work groups is that I get bullied and I get shoved under the table. This should be a public conversation. And we voted on this. We voted on this in December. And everything that you stated, the reasons of taking that off the table for the September meeting, are really invalid. So I'm asking that we today, as commissioners, vote to have Dr. Mawson come and present, so everybody can have information about his studies. An epidemiologist, a pro-vaccine doctor, with his CV is lengthy. His passion is there. He is very, very much involved in vaccine safety. So this is the conversation we had last year, and you've taken it off the table. And I don't agree with that, obviously, or I wouldn't be having this conversation.
So Karen, Karen, a bunch of you actually sent out a bunch of information about Dr. Mawson yesterday. And so people, I'm sure members have not, especially the new members, have not had a chance to review it. It's not, it wouldn't be reasonable to expect them to take a vote on something they haven't reviewed. They need to review that information and then digest that information and then have a discussion about it. It doesn't, that's because it's unreasonable to expect them. And the same thing happened in December, where you sent out the list beforehand, and we didn't have a chance to look into the study, those studies that you listed. So the same thing is happening again. No, people need an opportunity to be able to review and digest information so they can make an informed decision and informed vote. And at this point, that is not happening because the information was only sent to them last night, and I'm sure they didn't have a chance to review it.
Well,
and digest it.
The reason the information was sent to them last night because you got back to me last night. This
Okay.
has been going on for weeks. And I have to say that this conversation should have been had in January, February, March, April, any of those months. You're the one that pulled him off the table 9 months after he was voted in. So this is why it's so irritating for me as a commissioner, because you are there to help our meeting. You're not there to change our vote. That is not your job. That is not your position to change something that's already been voted on by commissioners. We all voted on it. We all agreed on that. And then you asked me in March to delay that. You never said a reason why. So you had 3 months to come to me and say, Karen, this is not appropriate, anything. That did not happen. It happened 2 weeks before this meeting. This is why I'm so unhappy about this whole conversation. Your job is to help support this commission and what we vote on. That's what you're there to do, not take things off the table and not keep penalizing me and not, you're the one that started this email yesterday. I've been asking you for this information in writing. You gave it to me yesterday. Now today, you're penalizing me again because you're getting me late information. I'm sure you're very busy, but you've had 9 months. You've had 9 months to give me a reason why you want to take Dr. Moxon off the table. And we all have voted on it. So this is backpedaling. This is part of the problem that the ACCV, we are not getting anything done. I've been on this board for 2 years. Very little has been done, and this is part of it, and it's outrageous. This is outrageous that we canceled in June, that we pushed back in March, and it's outrageous that we don't have the board full. It's outrageous that we don't have 9 members on this. And I'm on this board for 2 years without another parent. And thank goodness for Daniel, he's on here as another perspective of someone who's gone through vaccine injury. I am not on this board as a doctor or a scientist. I am on this board because I'm a mother, and my voice is equally as important as the 1986 created this board. This board is to have fair conversation, and I am unable to have a fair conversation. And if you want to look back at the first meeting 2 years ago in September, I was bullied by Dr. Moxon. I've been bullied by him in private work groups, and I keep hearing the same thing. No child has ever died from vaccine injury. I'm on this table because my daughter paid the ultimate sacrifice. And in the 2 years' time, I am not able to do anything because of this kind of shenanigans. And it is outrageous. So I believe that we as commissioners, because this is our job, we either agree to discuss this December meeting and vote on the December meeting. I'm not going to table this topic because this is an important part of our purview. And as you guys get ready to throw the COVID vaccine on and have more injuries for children, I am not going to back down. You're stuck with me for another year unless you want to kick me off this board. But it is my job. As I am obliged to Congress to do everything I can to make vaccines as safe as possible. And all I have done for the last 2 years is hit walls and be bullied and be put down. I am shocked that you took this off the table. And it is just wrong. And so if you want to push this off in December, go ahead, but I'm not giving up. This is the very first meeting I had the conversation about running a vax study, and I was so bullied and ridiculed and laughed at for having that conversation. And then IOM talks about it 4 different times. So this is not just Karen Kane being annoying. This is what the IOM has talked about. We need more information, and it is our duty, and everyone on this board should take the time to read emails, because I don't think thus far it's happened. This is our responsibility that we signed up for, to meet once a quarter, not just have things pushed back. We should have been having this conversation back in March.
So then if we review this data that came out last night, can we just discuss this information at the next meeting? Dr. Holloway.
Yes, that can be an approach.
I highly suggest that everybody look at the information, and we can have this conversation. It can be on the agenda, and then we can actually have people call in and make comments. We can vote on then, and then nobody has an excuse for not being able to have and go forward with this information. That seems to make sense to me.
And so what you want us to do is look at this data, look at these studies, and decide whether or not a vax versus unvaccinated recommendation should be given for HHS to do another study.
Yes, what I'd like to do is have Dr. Monson. I'm happy to have Dr. Brian Hooker. I'm happy to have Dr. Paul Thomas. I'm happy to have James Lyons, Dr. James Lyons, all scientists who have done back-and-back studies. I would like to open that conversation up for the ACCB so we can hear information. It is our job to look and digest this information and then make a vote on how we want to proceed. It's just what we're supposed to be doing. And what I'm having is a muzzle on having a vax-unvaxxed conversation. The very first time I brought this up, I was laughed at. And I've been bullied about this conversation. For 20 years, people have tried to get a vax-unvaxxed study done by somebody other than the CDC. This is critical information. We are at a critical time where the stakeholders are not convinced that having more vaccines on the schedule is the right thing to do. So obviously the CDC, everyone on this call except probably me is pro-vaccine. Let's give more vaccines. Let's give more vaccines. These vaccines have never been tested together, never have been tested together. These vaccines have never been tested with an inert sterile saline. That has never happened. And yet we
so what do we need to do to move forward?
Exactly, Karen. What do we need? Because what needs to be done to move forward? Because so the information was sent out last night, and I'm pretty sure, and we can take a poll if the members have reviewed it. So
I have not.
And don't blame me for that, Tamara.
So
don't blame me for that. You gave me that information yesterday, so don't put that on me.
Karen,
we're just trying to move on.
We're just trying to move on. Exactly. We're just trying to move on to the next step. And so the bottom line is, if they haven't reviewed it, then you can't expect people to take a vote about it. So.
And exactly. So by setting me up for failure, that's what happens. I'm happy to have this on the agenda for December meeting. I'm happy to have this on the agenda, and I'll send everybody out when we hang up the 40 other vax-unvaxxed studies, so we could choose any of them to talk about. I'm just asking it for it to be on the agenda because now we have to redo that vote. So now we're wasting an entire year, but that's fine. I'll play this game.
Well, this is Daniel. What I'm hearing is kind of two things, and related to the description of duties. Number 4, the survey of federal, state, and local programs and activities related to gathering of information on injuries associated with administration. That to me is an overview. As a new commissioner, I would love to have an overview presentation. I've read up over the years a number of different things, but I'm trying to pull it together to address what's in front of us now, and look at what's not there. What's not there. What are federal, state, and local programs doing to find persons that have been injured, and then from that, what I'm hearing is a recommendation for a specific recommendation to, it sounds like, the director of the National Vaccine Program to carry out something. That's what I'm hearing. And the other thing I'll just comment on is that I did get the emails. I guess I read them, but digesting, I didn't do the links and follow the studies. But I would say it's a process question about the commission, and that I'm a new member. And so I think it's a process issue that there might be some precedent or protocol for that.
So at this point, this topic could be discussed at the December meeting, because people by the time would have had a chance to digest what you sent out, Karen. And if you want to send out some more stuff, then they hopefully will have had a chance to review it and digest it and discuss this topic at the December meeting.
So this is on the agenda for the December. Is that what we're somewhat agreeing? We don't have to vote on that. We're just agreeing to that.
Yes, you don't have to vote on it. You can just agree. We can agree that the bottom line, this topic will be on the agenda.
And could we have a
Fantastic.
reading of that topic? What the scope of that topic?
The topic is discussing Karen's recommendation for a vax versus unvax study.
Okay.
Because that's what she plans to send out is additional studies around that topic in addition to what she sent out last night.
Okay.
This is David Kim. May I make a comment as an ex officio, not a voting member, on Dr. Mawson?
Yes.
I did review Dr. Mawson's paper, and I reviewed his credentials and among that and other documents that Karen had sent out. The document in question is not a study. It is a summary of other studies, and those are also not necessarily studies, judging by the references that were cited in Dr. Mawson's paper. And also, I hesitate to really focus on this paper mainly because it is published in Vaccines, plural vaccines. The standard bearer for it is very close to another journal that is often cited in immunizations and vaccinations. And that is called Vaccine, singular. And looking at the at other online articles that Dr. Austin open publications that Dr. Mawson had submitted, I believe there were 2 or 3 other articles. Although they were they're peer reviewed, at least that's what the documents claim, including this article in Vaccines. When I looked at the international journal standards for medical journal standards that Karen had also sent out, vaccines is not listed among those medical journals that have been, I guess you might say, approved or given the consideration for the journal being abiding by the rules of the International Editors of Medical Journals. So there are some issues here that I am not convinced would allow a forum such as ACCV for Dr. Mawson to present and discuss when there are these questions about the content. The article itself is like I said, is a summary, and the claim that there's injuries, that there are injuries associated with vaccines are hypothetical, and they're not substantiated by data, but they're hypotheses. So I just want to put on the record that I have reservations.
Okay, well, I would like you to take the time and look at the questions, because when Tamara took him off the table, she said that he wasn't a specialist in this field. She said his papers were retracted, and I'm not sure the third comment that we talked about orally, just the verbal conversation. So that was the reason why he got taken off. But then she sent out yesterday to me many questions and other information, which Dr. Mawson has responded to. Oh, and that his paperwork was retracted or redacted. And so I would like you to put that in writing, because I'd like Dr. Mawson to be able to respond to those accusations, because I'm not exactly sure what paper exactly you're talking about, because he has numerous papers. He's actually working on a new study today. He's a very well-respected doctor. He is a pro-vaccine doctor. And we all know, I mean, if you're on this board, you have to understand that vaccines cause injury, or the 1986 wouldn't be created. So we can't say that vaccines don't cause injury, please.
So Karen,
okay.
Karen, we're going to talk about, after people have reviewed what you sent last night and what you plan to send, we can have a further discussion in December. And so anything else, any other future business?
No, I think that
Okay.
sums it up for me.
So Dr. Holloway, did you have something to say before we end the meeting?
I was just going to express those concerns that when we do meet next meeting, we're
Mhm.
going to look at those articles and make
Yes.
a decision if they are appropriate to even try to vet them. And my concerns with what was mentioned by the ex officio member, that they were not can't be corroborated, and worried about his credentials, right?
Right. And so that's the purpose of giving you all enough time to review, digest what Karen sends out so that we can have a informed discussion in December. Yes. So is there a vote to adjourn the meeting and then a second?
Dr. Holloway, so move.
Second, anyone seconding? Seconding?
Second.
I second.
Okay. All right. Thank you, everyone. Appreciate your time. And thank you, new members, for joining us.
Thank you.
Thank you.
Thank you all.
Thank you.
Thank you.